Hi, everyone. So the next session is symptom management. As you all know, managing symptoms is very important, if not the main aim of treatment for Sanfilippo, for the best quality of life that all children and the family deserve. I will be chairing this session. My name is Siti Mubaraka. I'm a postdoc researcher in Childhood Dementia Research Group at Flinders University, led by Professor Kim Hemsley. Currently, I'm involved in a research project funded by Sanfilippo Children Foundation to develop a swift creation of a new neural cell model from skin fibroblasts of attenuated Sanfilippo patient, and use this to screen potential therapy. So there will be 3 speakers in this session. 2 of them will be joining us online. And it is my great pleasure to introduce the first speaker, Kimberly Murdoch. Kimberly is a parent to a child with MPS I, also known as Hurler syndrome, and is an advocate and a support coordinator for a parent of a child with Sanfilippo. She has significant experience navigating the Australian National Disability Insurance Scheme, or NDIS, and assisting others with their NDIS plans. She has a keen interest in supporting families, clinicians, and NDIS assessors and providers to speak the same language. Please join me to welcoming Kimberly.
Humanising NDIS, words are vital, bridging the gap between professionals and families. I use the word professional a bit tongue-in-cheek in my title because I refer to the people that work at NDIS, who some are fabulous. My presentation is going to be completely different to everything else you're hearing today. I'm neither a scientist nor a medical professional. I'm just a jaded parent with extensive incidental knowledge who isn't afraid to make waves. First disclaimer, I don't work for NDIS. I'm going to say some things that they wouldn't like. I'm pretty sure a little alarm goes off in the office when my phone number rings in. As I was so kindly introduced, I am Kimberly Murdoch. I'm a wife and a mum, and an autistic professional human. Both of my kids have additional needs. I've been dealing with NDIS since 2014. I've worked in aged care, disability, corrections, mortuary, and various other boring jobs. I'm a wedding and funeral celebrant. I love a good speech and a good fight. I haven't shied away from using my voice to help others find theirs, or in place of theirs if they don't have one. Now I'm using my decade of experience dealing with NDIS and other government systems for the benefit of others in a paid capacity. Second disclaimer to the families here. I will be using the word we throughout this speech, but I don't have a child with Sanfilippo. I will never pretend to know what it's like to parent a child with Sanfilippo, and it would be grossly insulting to pretend to. My oldest child has MPS I Hurler syndrome. They're non-binary and use they, them pronouns. They went through enzyme replacement therapy and then bone marrow transplant in 2017, age 2, shortly after diagnosis. That child is now 19. They successfully completed year 12 in mainstream education, have a certificate 3 in early childhood education, are living independently, working 2 part-time jobs, and despite significant ongoing medical issues, most importantly, they are happy. This is all thanks to Professor John Hopwood and the research team here in Adelaide. And there's not a day that goes by that I'm not infinitely grateful that treatment exists for hurlers. So while I'm not a Sanfilippo mum, I am an MPS mum, and I will say we, and I hope that's okay. So let's talk about NDIS. The NDIS provides funding to eligible people with disability to gain more time with family and friends, greater independence, access to new skills, jobs, or volunteering in their community, and an improved quality of life. The NDIS also connects anyone with a disability to services in their community. This includes connections to doctors, community groups, sporting clubs, support groups, libraries, schools, as well as providing information about what support is provided by each state and territory government. The NDIS supports over 500,000 Australians with a disability to access the services and supports they need. This includes supporting approximately 80,000 children with developmental delay, ensuring they receive the supports early so that they achieve the best outcomes throughout their life. Sounds dreamy, right? I wish that were the case. I'd happily be out of half a job, because half my job is spent dealing with and fighting with NDIS and the powers that be that determine how much funding a participant gets to meet their basic needs, let alone achieve all these fun things that I've just mentioned. There's an unrelated story about my business name. My wife and I have a disability support business. Animal connection is a huge part of her work, along with 20 years of training and experience working with tricky kids, hence everything is plausible. Irrelevant. How many scientists here, or doctors, have written a grant application? Probably most of you. Imagine writing that application and saying, please can I have some money because it's important and I just really need money. How successful do you think that application would be? In my experience, when parents first encounter NDIS, they start out nice, grateful, and NDIS will absolutely take advantage of this and give you the minimum. I dearly love and appreciate when I am proved wrong, and it has happened, but sadly it's not often. Most people I come across working within NDIS aren't even aware children can get dementia. Yet we know there have been over 100 neurodegenerative conditions identified as causing a childhood dementia. NDIS funding is based on evidence of disability. In recent times, they have shifted their focus to functional capacity over the diagnosis itself. Sometimes even with the evidence, you still have to fight. I can't imagine receiving a diagnosis of Sanfilippo for my child and then having to navigate NDIS, fight for the funding you need to meet their daily needs, and then fight for the needs you can't even imagine them having yet. And then fight some more every time the generation causes a significant increase. It's just not fair. So my tips. The benefits of a well-written lived experience statement by a parent or carer cannot be understated. Our norm as parents, no matter who you are, is to portray our children in their best light. But what we need to do to even get close to appropriate funding is to paint a picture of just how rubbish Sanfilippo can be to someone who has likely never heard of it. So as contrary to our instinct as this is, you have to be brutally honest. For many years, I've been sharing a lived experience statement I wrote for my younger child. He has the 3 A's: autism, ADHD, anxiety. People take this and personalise it and submit it with their evidence, and it's been quite helpful getting people better funding. Because NDIS don't often believe a mere mortal parent, though, a good functional capacity assessment by an occupational therapist is vital. It needs to be conducted by someone who at least understands childhood dementia and the progression. Ideally, someone who knows Sanfilippo, but I understand that's probably going to be rare. Also, get yourself a good advocate. Shameless plug. Be it a support coordinator or someone similar who can either work pro bono or charge in a different capacity building line. MPS is a marathon, it's not a sprint. This person is a team member who can fight alongside you when your strength is high, or fight for you when you're exhausted, or just don't feel like dealing with the government BS. We know life is hard enough without fighting the multiple government systems for our kids' basic human rights. Recently, I embarked on my most intense advocacy case to date for dear friends of mine. They live with Sanfilippo. This is Jordan. He just turned 29. He's 6'4" and 95 kilograms. He's currently very physically active and reactive. However, his brain functions at approximately the level of a 15-month-old because of Sanfilippo. Jordan lives at home with his mum and dad and requires 24-hour active care, usually by 2 carers at a time. He's intense, beautiful, but intense. As the effects of Sanfilippo had a greater impact on Jordan, a review was requested for further 2-to-1 carer support and active overnight supports. We know that with Sanfilippo comes the brain degeneration causing hyperactivity, interrupted sleep and insomnia. His review request was largely denied due to lack of evidence. However, I believe it was more due to lack of understanding of Sanfilippo. They did approve 6 months of active overnight support and direct Sharon to have Jordan undertake a comprehensive sleep study and education to improve his sleep hygiene. That doesn't actually sound like anyone that's ever dealt with dementia, let alone childhood dementia. Unfortunately, Sharon had no option but to follow this direction and take Jordan for a sleep study, which of course was deemed a massive failure within about half an hour. No one this advanced is going to comply while 22 electrodes are carefully placed on particular parts of your brain and body, or scalp and body, and various other meters are applied and then go to sleep. So then Sharon invited me to join the fight. Planning ahead, I helped Jordan's care team lodge another review for change of circumstance late last year when we knew there was about 3 months funding left. According to the NDIS Participant Service Guarantee, they will decide whether or not to conduct a plan review when requested within 21 days. So 21 days after I lodged the review documentation, I started phoning. And I was kind. I gave them 21 business days. I phoned fortnightly first, then weekly, then I escalated it, then I complained. Then I rang daily to escalate and complain. Despite my very best efforts, the funding ran out. It wasn't until Sharon told the local office in no uncertain terms, for anyone who knows Sharon will understand, that she would drop Jordan off to their office on Friday afternoon and invite the media to come along, that their funding was quite swiftly rolled over all of a sudden. Sharon was lucky enough that her youngest son took annual leave to help care for Jordan before that emergency rollover happened. I don't share this story with any pride because I do feel like I failed Jordan and his family by not getting that done in time. I share this story because despite having plenty of evidence from the doctors, carers, speech therapists, occupational therapists, sleep study nurse, continence nurse, and even a specialist behaviour support practitioner who detailed Sanfilippo, and despite me having a very simply broken down explanation of the funding needed down to the very large dollar, according to their price guide, NDIS still didn't understand or validate Jordan's needs. One mistake I made was mentioning that Jordan received services from palliative care. NDIS seem to sigh with relief when they hear palliative care. Seems to be their get out of jail free card, because the state government is responsive for palliative care, not the federally funded NDIS. Unfortunately, as with all things, PAL care is chronically underfunded and the services beyond stretched. NDIS doesn't want to pay for services it thinks PAL care should supply. And we know that PAL care can get involved almost as soon as there is a terminal diagnosis. But because NDIS, as with many people, think palliative care is just end of life stage, if NDIS believe that PAL care are there, that the client must be end of life. And that then their care falls under the medical banner and is not funded by NDIS. I believe in never coming to the table with a problem unless you have a suggested solution. I would love to see the Sanfilippo Children's Foundation develop a document that can be provided for parents and carers to add to their evidence for submission to NDIS. Maybe even something that can be customised so it's not generic. This needs to be comprehensive yet simple to understand, using the key NDIS language and the key medical information, bringing together the most important aspects of Sanfilippo syndrome and the care required for our children. We shouldn't have to fight as hard as we do for the funding we need, but it's the system we have, and at the moment, it is grossly flawed. With appropriate funding, there would be better outcomes for families as a whole, and often that has a flow-on effect to a reduced burden on the wider medical system. And also, with an appropriate funding, just a small bit of the stress that we live with can be alleviated, and our children could lead the lives that they deserve to. Thank you.
Thank you very much, Kimberly. If you don't mind to stay on this stage. That's amazing, amazing what you do. Thank you very much. So now is question. We're taking a question from the audience in the room and also online. If there's any question.
Thank you very much, Kimberly. Fantastic talk. Are the people from the NDIS who make these decisions ever invited to these types of activities? And if they are, and I suspect they probably are, do they attend? Because I think that will give them an insight into the depth of the problem and the very urgent and very significant need.
Absolutely. I think that would be an excellent idea. I think the trouble is, because it is such a huge system with so many little working parts, a lot of it is a call centre. So you call into quite literally a call centre like any other call centre that you ring, and they've got their checklist of things to do. A lot of the people there have no lived experience, let alone involvement in a community like ours. I think it would be excellent to get senior planners and that sort of level of NDIS at these events. I don't know how it would happen, but it would be great. So I can't really give you a definitive answer.
Any more question? Online?
From Chris online, she's asked or just said the Childhood Dementia Initiative is doing some work in the NDIS space. It would be good to get input from you, Kimberly, and the families in the room.
Excellent. Yes, that would be lovely. I've been speaking with someone there as well, so more than happy to get involved.
Is there any more question?
No.
If not, I think we can moving on to the next one. Please, once again, join me to thank Kimberly. It's my pleasure to introduce the second speaker. So she'll be joining us online. The second speaker is Lottie Morrison. Is Lottie ready?
Hello.
Oh, hello,
Can you hear me
Lottie.
okay?
Yes. So Lottie Morrison is a research assistant, a pediatric speech pathologist, and PhD candidate at the Murdoch Children's Research Institute and the University of Melbourne under the supervision of Professor Angela Morgan, who leads the speech and language team. Lottie was inspired to the field of speech pathology by a relative who had a disability and additional communication needs. Hand over to you, Lottie. Ready?
Thank you so much. I'll just share my
Thank you.
screen as I've got a couple of slides to share. Here we go. All right. Can you see my slides okay in the room there? I'm going to assume it's fine.
Yes.
Wonderful. Thank you so much for having me. So my name's Lottie and I'm a pediatric speech pathologist and a PhD candidate. As per my lovely introduction, thank you for that. And I will be focusing today on my PhD research, which is really focused on genetic conditions which cause a loss of skills in children. And so I want to give an overview of how understanding speech and language presentations, and as Kimberly said before, really improving clinician knowledge that is specific to rare conditions such as Sanfilippo syndrome can inform the clinical care for kids with progressive conditions and their families. So I know a lot of you in the room will know this, but just a brief background and overview. As Kimberly also alluded to, this grouping of genetic conditions which cause childhood dementia, they're very rare in isolation, but actually as a collective are more common than we may realise. This lovely work from the Childhood Dementia Initiative highlights this really well. And so childhood dementia is when there's a loss of skills that are progressive and enduring. And that's really the defining, definition for childhood dementia. So I'm going to be speaking to a few childhood dementias today, but namely Batten disease, which is the focus of my current research. And that was mentioned earlier as, sharing learnings between different progressive neurological conditions. And then, of course, Sanfilippo syndrome is a type of childhood dementia, and Batten disease and Sanfilippo syndrome are some of the more common, relatively speaking, types of childhood dementia. So I'm going to show you a video of a young girl with CLN3 Batten disease. So just pivoting a little bit and thinking about speech and language's first signs and symptoms of progressive conditions, both in adulthood and in childhood. When thinking about childhood and genetic conditions, we know that allied health professionals play a really core role in identifying whether a child might need a genetic diagnosis. And I think that's a real area of need, as particularly children who have speech and language as a first sign or a first symptom would see professionals such as a paediatrician, a GP, a speech pathologist, who might not, as Kimberly said before, even know that childhood dementia is a thing that they should be considering potentially. So I'm going to give two examples. The first is another form of Batten disease called CLN2. And we know that the vast majority of children, in some cohorts up to 100%, speech and language delay is the first sign, well before other symptoms. And also Kimberly mentioned that her child is had received enzyme replacement therapy. So there is enzyme replacement therapy now in CLN2 form of Batten disease. It's not curative, but it is a treatment. And it's important to get early diagnosis now more than ever, because there is this therapy option available to families should they choose it. And so another form of childhood dementia where speech and language is a first sign or symptom is, of course, Sanfilippo syndrome. So we know that approximately half of individuals with Sanfilippo syndrome have speech and language delays their first sign or symptom. And recent clinical guidelines really call for us to acknowledge that that is a first sign and symptom, often alongside other medical features or behavioural features. And misdiagnosis in Sanfilippo syndrome, like many childhood dementias, is common, and it's important to have timely referral to genetic testing. So understanding speech and language is, again, a mirror that's reflecting what's happening with someone neurologically to the outside, if you like, a sensitive marker to what's happening at a neurological level. So that as a sensitive marker, speech and language changes can show us how a disease is progressing. So a speech disorder might change in presence. For instance, a person might start having disfluent speech, or they might have a different type of dysarthria presentation suddenly occur, or their speech disorder might become more severe. And like language as well, there are things like grammar difficulties or word finding difficulties, and then social communication. So things like taking turns in a conversation or asking for help, those more practical communication functions. And as speech and language is a mirror, it can also mirror to us how an individual is responding to an intervention. So behavioural therapies like sleep interventions or medication like seizure medication, or for instance, when I was talking about CLN2 Batten disease before, the first trials in that enzyme replacement therapy used language as a core outcome measure to show that the intervention was indeed working. But really we need to understand how to characterise speech and language appropriately in these different conditions in order to utilise them as sensitive markers of progression and response to intervention. So in Sanfilippo syndrome, we know that communication and mobility naturally are very highly impactful for individuals and their family in terms of quality of life. And there's been some preliminary work done identifying the different speech and language features that occur in Sanfilippo syndrome, but this hasn't been systematically characterised in depth. So you can see some of the language and speech features I mentioned before. And we do, of course, know that there's changes across the disease course, but we don't really know what that looks like in detail. And a lot of guidelines and therapeutic recommendations suggest augmentative and alternative communication, or AAC. So this long term is basically anything other than speech to communicate. So that might be digital devices or visuals or gesture. And it's recommended that AAC, augmentative and alternative communication, is implemented as early as possible to kind of capitalise on, I guess, before neurological decline has really started to accelerate. So, but in saying that that's clinically recommended, there's no research to support or guide AAC decision-making in any conditions that are under the umbrella of childhood dementia, including Sanfilippo syndrome and Batten disease. So I'm going to finish up with a quick case study, if you like, thinking back to that young lady I showed you before who had the CLN3 form of Batten disease. You can see, like many childhood dementias, there are many support needs for these individuals. So a lot of motor challenges, including the speech disorder of dysarthria, loss of vision and seizures, and mental health, behaviour and support needs, and sleep disturbance. And so when we're thinking about all these areas, I think thinking specifically about, as I'm a speech pathologist, I'll be quite biased, but if I was a speech pathologist working with an individual with Batten disease, I think that condition-specific knowledge is so important, particularly when planning for future, and making sure that if we can help it, we're not wasting time implementing interventions that won't be sustainable or appropriate. So when thinking about planning for the future, for example, for that young lady we saw before, we're thinking about how can we maintain her current speech and language skills to the best of their ability, but also implementing measures that would, for example, support her ability to get her words out when she's getting stuck, or support her ability to find the right word when she's having difficulty retrieving it. How can we also measure speech and language to identify response to interventions, for example, if she's trialling a new medication or being part of a clinical trial? What AAC or assistive technology supports could we implement now and be proactive about teaching her before she loses her verbal speech? And again, thinking about Batten disease specifically, that loss of vision is a core aspect. So thinking about how we can support communication and understanding and reduce distress and frustration by utilising other senses rather than just vision. So hearing, for example, using music to indicate when there's a change in routine. And also communication partner training. So often the families are the real experts in these conditions and communicating with their child, but supporting them to communicate with people around them how to be the best communication partner for their child so that they remain as socially engaged as possible. So that brings me to the end of my presentation, and I just wanted to say thank you so much to the children and young people that I've worked with who have childhood dementia and their families. And as mentioned before, my wonderful PhD supervisors, Professor Angela Morgan and Professor Ingrid Scheffer. And thank you so much for having me speak. I'll stop sharing my slides now.
Thank you very much, Lottie. Great talk. So next is a question. We're taking question from audience in the room and also online. Is there any question for Lottie? So we have two in the room, Carissa and Kim.
Hi, Lottie. That was an awesome talk. I know nothing about speech pathology, so apologies if this is a little bit naive, but is there minute differences in speech capabilities across different types of childhood dementia, and then also like the developmental delays that are like the, in quotations, normal, what a neurotypical child might experience? And could these help with diagnosis?
That's an excellent question. So to date, characterization has been very general, speech and language delay. But like you said, could we find particular markers, for example, very specific changes in speech or very specific changes in language that don't fit under that umbrella of what you would say a typical developmental delay and really should be, if you like, red flags? But because characterization to date has just been speech and language delay with no real specifications and details, that makes it quite difficult, and that's across all the childhood dementias. So I think would be very, very helpful to have those specific clinical markers, and we're doing a bit of work, for example, things like getting speech acoustic data from these children and looking at them in a very in-depth quantitative way. I look like a DJ looking at their speech waves, sound waves. So looking at things that are objective markers that could tell us things that we might not even hear ourselves with our ears. So yes, I think that's something that would be very important, but unfortunately to date there hasn't been anything that could guide us in that direction under childhood dementia.
Yeah, great. Thank you very much.
Hi, Lottie. It's Kim here. Just to extend Carissa's question, if you're looking at very subtle changes in communication, I'm wondering if it's then possible to look and ask whether they're also measurable in some of our animal models. The first publication, to my knowledge, that actually looked at communication between mouse pups and their mum that had Sanfilippo type B was published in April. So we haven't really been looking at this as a community, and I'm happy to be corrected if I'm wrong, but I'm wondering if we can go beyond just looking at low communication, which I think was what they were suggesting in a Sanfilippo animal, to actually the quality of that communication, much like you're describing, needs to be done for patients.
Yes, absolutely. So one of the people I listed on that last slide, Professor Adam Vogel, does a lot of work he's helping with my acoustic speech analysis. That's what I said before with the speech waves. And he does a lot of work in mouse models and looking at speech, mouse vocalizations. Of course, mice don't speak, but have done some work in things like, creating those mouse models, but even things like stuttering and stuff that aren't progressive neurological conditions, just speech and language conditions more generally. So I think that is important for us to identify what could be clinical markers, not just from the animal models all the way through to people. And also you can imagine speech and language measurement is not very invasive. If it can tell us what's happening at a neurological level, but it can be done in a way that isn't distressing for the child or the family, can be done remotely at home and could allow for a lot of assessment time points, for instance. So I think there's benefits for that as well in terms of reducing the burden on families.
There's no one.
Hi, it's Lisa here, Lottie. Thanks for the great presentation. I'm interested in the concept of teaching the children to use assistive communication tools while they're still verbal. Is there a sort of a crossover point? Is there confusion in terms of them understanding how to communicate if they're being taught one way when they still have skills? I get that it's good to be proactive and get it in before it's too late, but is there any sort of level of confusion or crossover during that period?
Absolutely, that's a great question. I know we always say, like, this is what we should do, but realistically, when families have so much on, and also expecting them to teach a whole new communication system as well, there's got to be realistic. I don't necessarily think, I haven't heard any families say to me personally that their child's gotten confused. They will just choose the system that they prefer, which is often speech, because it is easier. But just exposing the child to that as much as possible, kind of like learning an additional language. So if we kind of see it like that, and if they use another system, like if they're still speaking but they use their other system, that's fine because we'll understand them anyway. So I think it's also very important to embrace any type of communication as successful, whether that be body language or vocalizations or facial expressions as well. Because we all do that sometimes in the absence of speech. So I think, to answer your question more succinctly, I don't think children will get confused necessarily, and I haven't heard that personally, although of course we have a lack of intervention studies. But I do think allowing a child a choice, what they can choose, what they would prefer when they've still got speech, if that makes sense.
Thank you, Lottie. One question more from the audience, and then we also have another one online, and then we'll go to the next speaker.
To add on, Lisa, to what you just asked, we introduced Auslan because my oldest was very speech and language delayed, and that actually encouraged the verbal communication a lot. And so it was really beneficial to introduce both. And also, jumping back on the NDIS, that no parent will get funding if their child is verbal for an augmentative communication device because they don't need it, quote unquote. And they are prohibitively expensive in a lot of the time. But I think it's an excellent idea to introduce it while the speech is still present.
Absolutely. I love that anecdote about, so we do know that there's a myth that still persists everywhere, and speech pathologists everywhere, that alternative means of communication can discourage speech. but really it's just like any communication is good communication, and we're really maintaining those skills and language and communication and motivation skills when we're thinking about progressive conditions, but then also bolstering them in children who might be experiencing just a developmental delay, for instance, not necessarily a progressive condition. Your point about NDIS, yes, incredibly frustrating. I think that's what you were saying about having something very specific to childhood dementia or Sanfilippo syndrome that families could use to advocate for that additional funding earlier than they might, and they might be seen to need it. And then also improving speech pathologists and occupational therapists, for instance, awareness, so that they can be sure to advocate for those things and even bring up those conversations with families early, so that they can, I guess, you're not introducing that conversation when families might have just far too much on for that to be introduced at that time. But yeah, I think having more evidence and resources would be excellent, because it seems silly that they shouldn't get funding for that, all things considered.
One last question online.
Yep, so it is, are there adequate AAC tools available or work to be done in this area?
It's a great question, Chris. No, short answer is no. There are a lot of, all the work done to date in AAC and dementia has been in adult populations. And then, of course, as we know in childhood dementia, and that example I gave of CLN3 Batten disease at the end, there's just, generally speaking, a more complicated, I guess, disease profile, if you like. And then also you're working with children who might not have already acquired these skills before they're losing them. So that's very different again from adult progressive conditions. You're working from a different baseline. So really the AAC tools that are available aren't entirely appropriate and have to be adapted, and they were originally designed for other conditions, for example, cerebral palsy. So I think it would be an excellent area for there to be more work done, because I feel like families are having to trial and error, and they're losing and wasting time where finding a system that works best for them. So yeah.
Thank you very much, Lottie. It's a fantastic talk. Please join me once again to thank Lottie.
Thank you so much for having me and for those lovely questions.
Thank you.
All right. Thank you, everybody. We're incredibly privileged now to have Professor Simon Jones joining us from the UK. It's incredibly early over there, and we're very grateful, Simon, for your time. Professor Simon Jones is a consultant in paediatric inherited metabolic disease at St Mary's Hospital and the Royal Manchester Children's Hospital. He's the clinical lead for the lysosomal storage diseases service at the Willink Biochemical Genetics Unit in Manchester, and has been actively involved in large international multi-centre trials across lysosomal storage disorders, but including Sanfilippo syndrome. Simon, very much looking forward to your talk today, and hopefully we can ask you to stay for a few moments afterwards for some questions. Okay, thank you.
Thanks very much, Kim. I hope you can all hear me okay. From the UK. I can't see any of the audience, so I can't see anyone nodding or shaking their heads.
We can hear you. Thank you, Simon.
Excellent.
And see you.
Wonderful. Excellent. Well, that's less good. So I will try and share my screen and try and appear less incompetent. I hope this works. Excellent. Okay, this all looks like it's gone smooth so far until at least I start talking. Thank you very much for asking me to be here, at least virtually. Wish I was in Adelaide. I have very fond memories of the international MPS meeting there some years ago. Yep. And I really enjoy meetings that are focused on Sanfilippo. They're few and far between, and there's so much work to get through. This is great. I'm kind of jealous, really. So I'm talking on a program that we've been running in Manchester, starting off in the university and moving through to the clinic for 15 years now. So some of you may have heard some of this before, but we are, I hope, making progress. It just does illustrate the challenges and the time and resources it takes to develop therapies in today's world. And so this is a program that we've been running on MPS IIIA, And I'm going to be primarily talking about a clinical trial in MPS IIIA using ex vivo lentiviral stem cell gene therapy. So I think you're all at this symposium very much aware of MPS IIIA. The important thing to highlight is that this is a disease that's refractory to allogeneic transplantation. Clearly, we use allogeneic hematopoietic stem cell transplantation in a number of MPSs with variable results, but clearly impacted on the neurological phenotype of these diseases. But when transplants have been performed in MPS IIIA, the feeling is that there's almost no impact whatsoever, very minimal biochemical impact, and almost no observable clinical impact, and perhaps a little bit more in MPS IIIB when it's done early, but still not as much impact as in MPS II and MPS I in particular. And the sense we've always had, although it's been hard to prove this conclusively, is that the amount of enzyme delivered is important. And clearly, as we've learned from other transplant programs in other metabolic disorders, timing, of course, is everything, especially when it comes to the brain. So our theory, quite a number of years ago now, was, and this is Ed Wraith's theory, it's always nice for him to be proven correct years later on, that was that if we could deliver early transplant in MPS IIIA with supraphysiological excessive enzyme delivery, then we may correct this refractory disease. So as many of you who've seen ex vivo lenti study or therapy schematas will recognize this is an autologous transplant. So we take hematopoietic stem cells from the patient. Those CD34 positive hematopoietic stem cells are sent to the lab where the lentiviral transduction happens. So no vector is given to the patient, just to the cells. Those cells are then frozen, QC check, make sure that what we want to happen has happened. And then once all those tests are complete, that's usually 6 to 8 weeks, we then condition the patient as if they were having a standard allogeneic transplant, but they get their own cells back. They're an autologous transplant, their own cells back, with hopefully the gene modified cells back with this overexpression. The patients getting their own cells back should mean a significantly safer transplant. So there should not be any risk of graft versus host disease. But we think at this stage have to fully condition the patients because that appears to be important, at least from the other MPS diseases, in terms of engrafting cells from the bone marrow into the brain. That's the plan. And so we started this off in a university as an academic program. We then licensed the vector to Orchard Therapeutics, who have allowed us to run a phase 1/2 study in Manchester. So that's Brian Bigger, who's just moved to Edinburgh in Scotland. Rob Wynne, the transplant director, and myself, all sort of trying to pursue this program, as I said, for quite a long time. We recruited 5 patients during COVID, hasten to add, with a neuronopathic MPS IIIA, so the classical phenotype. This was very important. There were no comparator arm, and so we wanted to be able to predict the outcome and the phenotype of these patients should they not have treatment with their treated outcome. We followed them now for essentially 3 years. So we have data now from 3 years. Of course, this is an early stage study, first in human study, so it's about safety, tolerability, but we want to learn as much as we can from every single patient treated, because clearly there are risks in a study like this. And we can't afford to treat too many people. So we treated 5 of these very young, so patients with Sanfilippo A, known to have a classical phenotype under the age of 2 years. So that was challenging recruitment. You know, the average age of diagnosis, of course, in MPS IIIA is about 3 to 4 years. And so out of these 5 patients recruited to the trial, 4 out of 5 of them had an older sibling diagnosed with MPS IIIA, and they were picked up because of family screening. So a variety of ages, as you can see, these patients were recruited internationally because of the difficulties of finding this small subpopulation of MPS IIIA kids. And we've now got slightly more than in this chart follow-up. The variants were all consistent with the classical form of MPS IIIA. That's important because one patient who did not have an older sibling, we had to be sure on their genetics, of course, that they were that genotype was consistent with a classical severe rapidly progressive phenotype, and we had an independent rater of the genotypes to help us be absolutely sure that we were including the right patients. The cell doses and things, if there were transplanters around, they get very interested in these, but essentially the vector copy number, we had good cell doses at each transplant, and the vector copy number in the transplanted cells was adequate and within our range. And we can talk a little bit about that later on. The conditioning regimen and transplant support is very much as we would do for a straightforward allogeneic Hurler transplant. So that's full intensity conditioning with busulfan, and then the usual aggressive transplant support that has led to the fairly good safety outcomes we see in Hurler transplant now these days. Engraftment kinetics on these patients were essentially entirely as predicted for an autologous transplant, so fairly rapid and good, with the only delay in one patient 3, who had a bit of CMV around the time of the dosing with the cells, but nothing significant there. In terms of serious adverse events, none of these were felt to be related to the IMP. And of course, in the ex vivo autologous lenti world, the investigational medicinal product is actually defined as the gene-modified cells. So that's not the vector, that's the gene-modified cells. But despite us trying to take out all of the SAEs that we might expect being related to conditioning, etc., in essence, we felt that most of these sort of 4 out of 6 of these SAEs were related to transplant, things like fever, infections, and VOD, with a couple of these SAEs being related to what we see in terms of Sanfilippo. So one patient was noted incidentally to have a subdural hematoma at routine imaging, and we've seen this in really quite a number of MPS III patients as a generally benign, although not always, and a finding and appears to be related to the underlying disease. I've seen this in a number of patients on our MPS IIIA intrathecal enzyme trial back in the day, and indeed in at least one patient on the genistein trial, and in 2 or 3 patients who we were following up clinically. So this is felt to be very much a MPS III phenomenon, and was asymptomatic and has not recurred. The only other complication was a patient who was over-sedated following a general anesthetic for an MRI scan and lumbar puncture sometime after dosing. And we were not terribly surprised, as we always have challenges sedating children with Sanfilippo. The usual challenge is that they don't sedate at all, but just occasionally they over-sedate, and that resolved. Good. So let's think about the biochemistry here. Let's look at what happens to patients after the transplant. So we're looking at enzyme level, so the SGSH enzyme deficient in MPS IIIA. Let's look at this enzyme level in leukocytes. These, of course, are the transplanted cells. So as you would predict, there is a massive increase in leukocyte SGSH activity. In fact, several hundred times, in some cases, the normal amount of SGSH activity. So that's massive supraphysiological expression of the enzyme. We had to, in fact, redo and redefine our typical leukocyte diagnostic assay to cope with the exceedingly high amounts as we were using up all of our substrate. And so, yeah, so that was a lot more than we actually thought. But again, there was no evidence of toxicity that we were able to observe in cells from the overexpression. Looking at can those cells with that massive expression inside the cell of this enzyme, can the cells actually export or secrete that enzyme? Well, again, we weren't entirely clear with this huge overexpression whether we would just overwhelm that allegedly 10% of enzyme that is secreted from the lysosomal system. And in fact, we were able to show this by looking in plasma. We can see a significantly increased plasma level of SGSH. This is not a very well secreted enzyme. Generally, some of the lysosomal enzymes are secreted very well, but this isn't typically one of them. And we see a significant, although not quite as dramatic, over expression and over secretion of this enzyme. Of course, we're trying to treat the brain. There are many extrasomatic features of MPS IIIA, which we don't want to ignore, but our primary outcomes are going to be, and have been generally in trials for Sanfilippo, about the brain. We can't measure brain like we did in the mice, and so we measure CSF, hoping that that's as close. We really had to work to validate a CSF enzyme assay for sulfamidase for SGSH. It wasn't something we've ever done in the past. We thought it might be very like the plasma assay, but it wasn't. There's a lot of extra stuff, phosphates and sulfates and things in CSF that interfere. And this is also relatively sensitive to freeze-thaw cycles. And so that took maybe 6 to 12 months of work to really ramp up this assay. There's not a lot of enzyme in CSF. It's an acellular fluid. So a tricky fluid to be looking in when all we've done is replace cells. And so we spent a long time making sure that we could measure SGSH in healthy individuals in their cerebrospinal fluid. And we're very reassured to see that these individuals indeed not only expressed SGSH in their CSF after transplant, but this was in most cases supraphysiological. Although interestingly, the kinetics seemed a little bit delayed to us compared with the kinetics of expression in blood, which again has been commonly mooted as one of the issues we see with a transplant cell-mediated enzyme delivery system, is that there does appear to be a delay in delivery to the CNS. The vector copy number, I showed you this very briefly early on in terms of the cell product. So we measure the vector copy number, that's how many copies of the viral genome and the SGSH gene are now within the transplanted cells. So we measure that in the cells before we put it into the patient, and we then measure it in the patient, both from bone marrow, leukocytes, and multiple different cell lineages. Why do we do this? Well, we do this because the promoter here is a CD11B promoter. So for those of you not immersed in lentiviral promoters, which I suspect will be most of you because you have a life, then this is a myeloid promoter. And in fact, yes, that would be very much borne up by what we see here. And myeloid cell lineages are the most impressive with regards to expression of this enzyme. As we'll see, oh, sorry, I haven't shown you that. That was the VCN. I'll show you that in a minute. Yes, so we move on from enzyme to heparan sulfate as our substrate. We want to show that not only do we deliver supraphysiological enzyme to the right compartment in the body, that we actually that enzyme is active and degrades substrate. So we see a very dramatic reduction in plasma heparan sulfate, complete normalization in all patients of the urinary heparan sulfate. And when we slipped those urines into our diagnostic lab, they weren't able to detect anything different from normal, despite our diagnostic lab being very experienced at this. And if I can just move my, I can't quite see the CSF graph, but we can see a dramatic reduction, well over 90% reduction in the CSF heparan sulfate, also, which we don't see, of course, following an allogeneic bone marrow transplant. We don't have unfortunately, have a normal range for CSF heparan sulfate yet, which is frustrating because we think must be pretty close to that. But the laboratory doing the CSF testing for us is in Amsterdam and hasn't felt able to have enough normal, healthy children of different ages to develop a normal range. And just to say the urinary gag ratio, as I said, entirely normal. In terms of safety, it's a big deal now, of course, always in gene therapy. There have been concerns from Bluebird Bio that some of their programs are showing a small number of individuals have shown a myelodysplastic syndrome following lenti gene therapy for cerebral ALD. And so this was always important, but it's clearly important for us. Our integration site analysis really suggests a very multiclonal product with a large number of integration sites. And the top 10 integration sites in our patients encompass are less than 3% in total. And so when we do the integration sites in different patients, the top 10 are not the same top 10 in each patient. I think that's what's fair to say. And maybe that slide doesn't say that. I think that's really important that we've not seen in 3 years of follow-up anything concerning regarding myelodysplastic syndrome, but clearly remain very vigilant for this. Antibodies against the transgene product. We have been interested in this for some time, both from enzyme replacement therapy and also from gene therapies. And we do see these are severe Sanfilippo patients, many of whom express almost nothing in terms of the SGSH protein themselves. And so following such profound overexpression and presentation of enzyme to these patients, remember it's an auto transplant, so they still have their own immune system. We do see an initial spike in antibodies against the enzyme, but these fall off in a pattern that's very familiar following allogeneic transplantation. So if we have an MPS I patient who's on enzyme, who's very sensitized to that and has vast amounts of antibodies, and we transplant them, then we see the antibodies decline with exactly this sort of kinetic. However, the difference here is that antibodies against SGSH are actually, in general, very low titers when compared with the inhibitory titers we see in MPS I, II, Wallman disease, Pompe disease, etc., with most patients having what we would think of as very unlikely to be functional antibody titers. And clearly, there's no correlation with biochemical outcomes given the reassuring biochemistry. This is, of course, something that we're just exploring and just trying to understand, and we'll keep a close eye on. In terms of the neurocognition, now this is, of course, what we want to be really trying to impact and affect, and what we want to be achieving in the end, really. We can measure neurocognition with a wide range of tools. And we started off by doing this primarily using age equivalent scores. And that's sort of trying to match the developmental age of the child with the chronological age of the child and comparing this with the natural history of MPS IIIA. Perhaps we've had to adjust this over time as the thinking in the field has changed. And those of you who attended the World Symposium will have heard Elsa Shapiro arguing strongly about the importance of growth scale values and the challenge in some cases of using age equivalent or standard scores in neurodegenerative disorders in childhood like MPS IIIA. And so I think what's clear is that we're all still struggling to work out the best way of measuring and assessing neurocognition in trials, and that includes regulators as well as clinicians and academics and industry. We really want to try and assess behavior and quality of life activities of daily living in this disease. This is very important to everybody, but importantly, I think we're still struggling to know how to measure these in a really clinically meaningful way. This is my third or fourth Sanfilippo trial. And so the fact is I still don't know how to measure that properly. We did treat one patient, which we called a specials patient, before the study started. He was treated much later in life. He's about 2.5 years of age when he started treatment. His outcome was that he hasn't lost any skills. He's now 6 years post-treatment, but he hasn't lost any skills, but he's not gaining skills, and he is behaving much more like an attenuated Sanfilippo patient. That, for us, stressed the importance of early treatment. And we wondered whether we should go even earlier than 2 years. The challenge, of course, is finding patients at that stage. So the early follow-up of trial patients shows a gain of skills and continued gain of skills after treatment in 4 out of 5 of the treated clinical trial patients. We're seeing developmental gains never seen in untreated severe MPS IIIA, including acquisition of complex speech. In 2 cases, children are bilingual, although there are some slightly unusual facets of speech which we're just starting to investigate now as children are getting slightly older and are getting to 4 and 5. We see in children who are fully continent, children who are engaging in complex play, including role play. And I always look at this young man on the bottom right here, who's been given a cup of liquid with no top on it, which isn't something we generally give to children or children with Sanfilippo, as they usually get thrown. He's also wearing glasses and a mask, which again we tend not to see in our young children with Sanfilippo. When we look at the neurocognitive scores, the graph on the left here is of our 5 patients. You see the 4 of these 5 patients continue to gain skills, mostly consistent with the normal range, and those 4 children are now starting to diverge significantly from the natural history. The natural history is the light grey lines from the Shapiro paper, plus a few extra patients from some of our previous work in Manchester, where we've been assessing patients pre-treatment. And so we're beginning to see really dramatic change. And in fact, 4 out of 5 of these patients have actually crossed from being assessed on the Bayley's scale, which is the standard test we would use for young children with Sanfilippo. And however, the Bayley scale only goes up to 42 months in terms of where you should be with normal development at 42 months. We've never, with a classical Sanfilippo child, progressed beyond the Bayleys to another more complex age-appropriate test, because by that age, the children have plateaued. Children with Sanfilippo typically have plateaued and are then starting to lose skills. So we've never had to do this progression to the next test. The next test we had decided to use is the Kaufman ABC, and we've now tested 4 children in the Kaufman. They've gone beyond the ceiling of the Bayley test. So we're trying to work out how to show crossing from one test to another. That's somewhat complex, but as we get more data, that should be easier to show. The one child who's not gaining skills is unfortunately our first patient on the trial, and biochemically they don't look any different from our other patients, and we were very concerned about quite why this may be. This doesn't make a lot of sense. We've tried looking in this patient for there's no signs of graft failure. There's plenty of enzyme being delivered. The substrate reduction is beautiful. This child, however, has an older sibling with Sanfilippo. The family are quite clear that the phenotype of the 2 patients is very different, even though the younger child is not progressing in terms of actual skills. She isn't developing classic Sanfilippo behavioral patterns, but instead is following a more classical autistic type progress. There is a history of autism in the family, but we're very reluctant to blame that. We've tried looking way beyond SGSH for other explanations for this. Interestingly, also her MRI scans, we haven't been able to get the quantitative volumetric scores on the MRI scans, but her MRI scan, I think 2.5 years post-transplant, was reviewed by our neuroradiologist. He said it's essentially normal, apart from some perivascular changes that we see in everyone with MPS, irrespective of cognition, which would go along with the fact that we've prevented a neurodegenerative process. So understanding this child, I think we're seeing her next week, and we'll test the wider family as well as this child to try and understand this phenotype a little bit more. It's important, however, that we don't brush this under the carpet, and we take and learn from every single one of these kids. To conclude, we think our treatment was well tolerated, despite, of course, there being risks with a transplant developed or transplant derived therapy. We're seeing engraftment in an appropriate way of genetically modified cells. We're seeing excessive supraphysiological levels of enzyme in all of the compartments that we can measure, which is accompanied by a rapid and dramatic, significant reduction of substrate in all of the compartments. We're not seeing safety concerns in terms of insertional mutagenesis or oncogenesis, and the neurocognitive data early on. And although we're 3 years out in a trial that's been running for, I think, 5 years now in total, we're still early in terms of our neurocognition. And importantly, 4 to 5 patients have progressed to the next instrument in our developmental scales, which we have never had to use in our institution in a severe Sanfilippo patient. So I want to thank the vast amount of people who've helped us do this. This has been a 15-year project, and we're now working with Orchard Therapeutics, who own the license for this vector now, to talk about how we would continue to follow these patients up and hopefully move on to a new study with more children. Thank you.
Thanks very much, Simon. That was a beautiful presentation and some really exciting and encouraging data. Wondering if there's any questions in the room or online.
Hi, Simon. My name's Jill. I've got 2 kids with Sanfilippo A. They're both attenuated. I was wondering whether there would be the potential of, for the next phase of the trial, including attenuated patients. They are older, so they're 11 and 8, but they're not losing any skills. So I thought, is that something that you would consider? No, I'm not talking about me specifically, but just attenuated in general would be good.
Yeah. You ask a fabulous question that keeps me up at night, actually. There's no doubt when we look at many of the conditions like Sanfilippo, many of in our field, that the small number of attenuated patients that we see, like your children, are would almost certainly be the best kids to have in these sort of trials. They surely must be easier to treat. They already have a little bit more enzyme in those cells and maybe need a little bit less. And probably also the window for intervention in attenuated cases is much wider than it is for these really severe, rapidly progressive kids. The problem, as always, is that there tend to be, and are in MPS IIIA, more of the classical rapidly progressive kids than the more slowly progressive attenuated kids. And the attenuated kids tend to be more variable. So whilst each child with MPS IIIA follows their own path, you can make some broad generalizations about the classical kids, whereas that's an awful lot harder to do with the severe kids. With the attenuated kids who follow their own path. And of course, I've shown you a study which has lasted nearly 5 years already. We've nearly gone broke several times during the course of this study. It's lasted 5 years, which is very long in a clinical trial sort of setup. for a long time for a clinical trial to run. And actually, we're only just beginning to show, even with the really severe kids, that we're actually beginning to divert from the traditional Sanfilippo phenotype. And a lot of people want to see more data before they're fully convinced. And so whilst I think we would all recognize that kids like yours would be the best kids to treat, what we're being forced to do now is not treat kids, but prove a point. Where I've been asked to answer a question by the regulators, which is entirely different from trying to treat kids. And that's the challenge we all have. We've had there's a move at the moment in our field globally to try and persuade regulators that people who regulate drugs, who approve drugs, who allow trials like ours to go ahead, that the way we do this is wrong. That the way we do this, the way they make us do trials like this, forces us to use the most difficult patients to treat, because they tell us they have to see clinical outcome measures. They have to see the development change, and the longer a trial runs on in terms of years, the more it costs. And we're a small academic unit. We got some funding from Orchard, but this this trial has cost over £6 million already. Hence we've been struggling. Everyone's struggling to run trials like this. And money is now one of the greatest obstacles to running more trials like this, because of the way we're forced to run these studies. Our discussion with the regulators is all about, can we use CSF heparan sulfate as an endpoint, getting a quick and a quick readout that might be available in a year's time, and that would be available in all patients, whether they're severe, less severe, however you want to term them. And then if you were to get a conditional approval or accelerated approval or an early approval on that, there would be a requirement to follow those patients up for maybe 10 years. Because for the attenuated MPS IIIA kids that I've seen, and even young adults that I've seen, you would probably need to follow them for 10 or 15 years to really show that you have a really meaningful, you've really altered their life in a meaningful way. And I haven't yet met any company or, in fact, government institution who's going to fund us to run a study for 10 or 15 years. And so there has to be a way in which we change this, and change the approach, because I think the current approach is killing programs. We've had a vector sitting in our university or thereabouts for 6-7 years now for MPS IIIB that should work just as well as this one, but we've not been able to get any funding to bring it into trial. And that, for me, is just immoral, because I've seen a lot of MPS IIIB kids in that time, many of whom would have been eligible for that trial and can't move ahead. So at the moment, trials take too long, they're too expensive. It's taken us 15 years, and I've only just finished our phase 1/2 study, and we're only just beginning to talk about the next trial. You know, if we repeat this for every rare disease, every rare neurodegenerative disease in childhood, we've got an awful long way to go. And I wasn't white and I didn't look this old when I started this project. So, you know, you make a really good point. It seems, you know, and listening to families, you absolutely get the absolute cold logic in this. That's not what we're being forced to do at the moment. But I think I think patient groups and industry and academics and clinicians are all coming together to say clearly to regulators that the current system is failing, and most of all, it's failing our kids. Sorry, a very long answer.
No, thank you. I appreciate it.
I think we have a question online, maybe even two.
Righty, so we've got a question from Chris, which is, have you compared the data from the Abeona or Ultragenyx AAV trial to the data you're gathering? Is one looking better than the other?
Yeah, that's a tricky question. So obviously, these patients are not directly compared. there were some differences as from what I could see. I personally, this is my third treatment trial in MPS IIIA or various MPS III subtypes. I just want there to be some treatment for MPS III in my lifetime. So I preferably would have multiple treatments succeed. Whilst this is one that I've worked on the longest, I want as many treatments as possible to succeed. It's hard to directly compare those studies. Obviously, the Abiona now Ultragenyx trial was an intravenous AAV trial. There were multiple dose levels, and there's been multiple age ranges of patients with MPS IIIA treated. So again, it's hard once again to try and take one of their graphs and superimpose them on one of our graphs. I've sent some of my patients who weren't eligible for our study to that study and to get treated, because I'd much rather, patients, all of our patients get an option and get the best option they have. So I've been tried to be as supportive as I can of those projects. The other ways in which it's difficult to overlap the populations of MPS IIIA patients is that, from my understanding, the Abiona Ultragenyx trials excluded patients with big deletions or very severe mutations in the SGSH gene because they were slightly worried about antibodies and immunogenicity. So those most severe patients who we were selecting for, if you like, because we were wanting them to have a severe mutation and to be really clear about the phenotype and what type of MPS IIIA they were going to have, we were probably enriching our population with that kind of patient, and they were excluding that kind of patient. So we're probably, whilst our populations are overlapping, they're not exactly the same. I think when we look at CSF heparan sulfate, if that's an important endpoint, we think that's an important endpoint. Do we know for sure? We hope it's relevant and important, and there's lots of data suggesting it's probably linked and closely related to brain heparan sulfate. But again, is that always the case? Depending on how you treat the patient, et cetera, I don't think we know absolutely. They measure CSF heparan sulfate in a different laboratory and report it in a slightly different way. So it's quite a challenge for us to compare that. I think our data looking at the biochemistry are probably slightly more homogeneous. But what we see in terms of this slight variability in the outcomes of the patients, they're also seeing from what I can see in their developmental outcomes. My understanding is that they're more recent cohorts because they've had a lot of different dosing cohorts with different doses and different ages. My understanding is their most recent cohorts have had a much more similar, so very young, very high dose. So I think as time goes on, we may be able to compare and contrast. Of course, we'd all want to do that. Again, the regulations don't allow, frustratingly, us to compare treatments. We always have to compare treatments either against placebo or in natural history. Unlike in childhood cancer, when government sponsor trials usually rather than companies, and you get to compare treatments with each other. I don't think that's going to happen for a while.
Any other questions in the room? Yes, Carissa.
Simon, that was a fabulous talk. Thank you very much for sharing all that data with us. I was wondering about that. Is it patient 3, that red one that's not progressing in the same way as the other ones that you couldn't distinguish biochemically? What your plans were to try and work out what's going on with that particular patient? Because there's a omics type analyses planned.
Yeah. So we're going to look much more beyond the standard MPS markers, which at this point haven't helped us differentiate that. We're going to relook at the genomics again, and actually we're also going to investigate the wider family in more detail. The autism side of it is something that intrigues me. So when we look at our MPS I hurler patients, we've done autism screening and found that 23% of our transplanted hurler patients have diagnosable autism spectrum disorders. And that seems to be more common in families where there is already a history of autism or autistic traits, but clearly 25% is a lot higher than the background population risk of autism. And I guess our question that's forming in our mind is whether they're, given the overlap of some of the behavioral phenotypes of MPS II and MPS III, of course, with severe autistic phenotypes, is there a mechanism by which heparan sulfate at a particular time in the development of the central nervous system could lead, no matter what happens later on, to an autistic brain, if that makes sense? I don't know. I mean, that's the kind of hypothesis that we're thinking about now, in that when we look at the autistic hurler kids post-transplant, they're not treated later than any other of our hurler kids. They haven't had a worse graft. They don't have less enzyme. There's no way of discriminating them. And so it may be something to do with a haplotype and background modifiers, background risk factors. Or I'm not sure. Perhaps, Kim, you may want to comment on heparan sulfate and what it does to the brain.
No, I'm with you. It's baffling. And yeah, omics approaches may help. I wanted to ask a question, if I can. Your patients might be too young, but I'm wondering if you're planning on looking, or if you have looked at the retina to ask whether photoreceptors are being maintained.
Yeah, it's a great question. Given all the recent data, looking at sort of very attenuated MPS III ABC with retinal disease or isolated retinal disease, I mean, certainly it's something we see as part of the phenotype in older MPS IIIA individuals as they get into late teens, early 20s. We do see some evidence of retinal disease and night blindness. These kids are, whilst not too young to test, are beginning to get into that age range. And we've just sort of been amending the study so we can, once they're sort of 5 or 6 years old, start to look at some of these extra neurological features. So we want them to start looking at joints and the heart and the eyes and all of this, because, whilst we deliver more enzyme to the periphery than we do the brain, we would certainly hope that we would improve cardiac aspects of the disease, the hip aspects of the disease, the GI aspects, which can be so problematic. The retina is a really interesting question because it once again, like the brain, is somewhat protected. So we will be very interested to see as they reach teenage years what's happening there.
Thank you. One more question.
Thanks. Hi, Simon. Lisa here. Thanks for the great talk. I wanted to ask about what you think about the longevity of the effect of the treatment. So the gene goes into the bone marrow cells are then that's permanent. They're continually regenerating and sending out more cells into the rest of the body. So the cells that have gone and taken up residence in the brain, are they continually turning over from this bone marrow supply that's corrected? Is that going to be a permanent fix? Does the gene ever get spat out of the bone marrow? So really, is it going to last for a long time, the treatment, the SGSH that's there?
Yeah, great question. It's one that is asked a lot about. So I mean, there's a difference here between AAV and lenti in that there should be less risk of that because we integrate into the genome. Of course, that has risks, and so you take that, what you hope is a certainty of continued expression, because you've integrated into the genome. You take that along with the potentially increased risk of oncogenesis. So we haven't seen any evidence of decreased expression of the transgene in our patients, but of course that's only 3 years. However, when we look at MLD patients who've had lentiviral mediated gene therapy 10 or 12 years ago, they have no evidence of a decrease in expression of that enzyme over that time. And there's some of the even earlier primary immune deficient kids with ADA SCID and similar things who again, and again, we're all using Aldini backbone here. It's a very similar vector, slightly different promoters, which probably aren't going to alter this. The promoters probably just alter the amount of expression you get. And so there's no evidence of that so far. Your question about what happens, the relationship between bone marrow derived transduced cells and CNS resident transduced cells is a slightly more complex one. We think that bone marrow derived cells go to the central nervous system fairly soon after the bone marrow transplant, and then gradually do something. What they become is a matter of a lot of debate, and they seem to take a little bit longer to make enzyme, and they seem to be microglia-like, but not quite microglia. So all of that is a matter of some debate, but they probably go there fairly quickly, and then they probably stay there. And I don't think there's a constant repopulation. The only circumstance where we've seen regular repopulation of bone marrow derived cells into the brain is where you have a neuroinflammatory insult. So if you have a brain tumor, for example, or a neuroinflammatory disease, then you can recruit peripheral macrophages to your central nervous system. Of course, we're hoping to eradicate the neuroinflammatory phenotype of Sanfilippo, so we'd hope that wouldn't be happening, and we would therefore hope we wouldn't need to keep doing that, if that makes sense.
Okay, I think we're right on time, Simon. Thank you very, very much for getting up early. Hopefully it's a beautiful late spring day there in the UK and you can get out and enjoy it now. If you can please join me.
Even sunny in Manchester, Kim.
Beautiful. Get out and into it. All right. Thank you very much, Simon. And can you please join me in thanking Simon for a lovely talk?
Thank you, Kim. Thanks again, Simon. Thank you to all the presenters and panelists and everybody that's participated in questions today. Last word of the day for Gillian, who is going to reflect on what she's heard today and share her thoughts.
Hi all, can you hear me? Hello. I'm Jill. I'm sure you've all heard from me before. My husband and I have got 2 kids with Sanfilippo. We've got 11-year-old Rory and 8-year-old Anna. So firstly, thank you to the Foundation, Karen, Lisa, Danny and Rebecca for bringing us all together here in beautiful, overcast, cold Adelaide. I can't handle it, I'm from Brisbane. And also special thanks to the Commonwealth Bank for their grant, which allowed our Sanfilippo families to come here and be here in person, which we really appreciate. So I know the primary goal of today is to present research and discuss ideas and hear feedback, etc. But we also really appreciate the opportunity that the symposium provides for family connection. As we heard from Sarah, it can be really isolating having kids with such a rare condition. So to have the opportunity to make connections with other parents who are traveling a similar path, it's a bit like a warm hug. So we really appreciate it. Thanks to Professor Kirk for discussing carrier screening. It's something that I'm particularly passionate about. Being a carrier for such a devastating genetic condition, it's just not in many prospective parents' psyche. It wasn't in mine. Unless you work in this area, you don't walk around thinking that this is what you've got inside. This is what you could be bringing into the world. So we just need to be having these discussions with young people, I think, even in high school, well before babies are on their mind. So we just need to spread the message that carrier screening is a thing and it's something that we should all consider. So thank you to Mackenzie's mission for being a pioneer in this realm, and I fully support the widest panel of genetic testing available for all prospective parents. Thanks to Dr. Sue, who spoke about newborn screening, which would be the second tier defense against Sanfilippo. We can't just, prevent children from being born in the first place. You've heard me say it before, there's only one thing worse than receiving this diagnosis for your child, and that's receiving it for 2. So I acknowledge how difficult it would be to have received the diagnosis at the newborn stage, but if I'd had the chance, before I had a chance to connect with my son, but we're going to get the diagnosis eventually anyway. So having that early diagnosis, we would have it would have opened up a lot of opportunities for us. We would have had early intervention. I wouldn't be tearing my hair out at night at 2 o'clock in the morning, researching, wondering what's wrong, what's going on here with my child. And ultimately, it would have given me options to prevent having an affected second child who's going to suffer the same fate. So that's my feedback on that. I know it's a bit hard for us lay people, parents, to keep up with the research that's been presented today, but it's extremely encouraging that we have passionate scientists like you all who are dedicated to curing this devastating disease. The brain in a dish results were particularly exciting. My 2 kids' neurons are involved in this research, so I hope they're behaving themselves. They're like chicken nuggets and Vegemite sandwiches. So I really look forward to hearing more as you move on to the next stage, and ultimately maybe individually targeted treatments for our kids is on the horizon. So it's exciting to think that one day when a parent is sat down in that horrible, scary room in the hospital and told that your child has Sanfilippo, we're not told to just go home and love our child. There's nothing you can do. Instead, we'll get to hear, here's the treatment plan. So that's very exciting. So thanks to Kimberly for advocating for us, and for Geordie as we navigate the sometimes painful enigma that is NDIS. And finally, thank you to Sarah for sharing her gorgeous son Callum with us. He's seriously one of the cutest kids I've ever seen. Look, we hear you, you're not alone, and your story is our story. And while we're scattered all across Australia, we're here for each other. And it's clear that everyone in this room is here to support us and our awesome kids too. So thank you so much.